Welcome to the Getting Down with Digital Health podcast, sponsored by Ment. We hope to inform and inspire you on a wide variety of healthcare topics. We're grateful you're joining us today. And now, on with the show.
What up, everybody, and welcome to another episode of Getting Down with Digital Health. I'm your host, Brandon Worley. And joining me today as co-host is my fellow co-founder and Ment CEO, Matt McBride. Matt, what's up, man? How you doing?
Doing great, Brandon. Great to be here. Should be an awesome episode.
Yeah, we're very much looking forward to it. We are very honored and excited for our guest today. We have Dr. Matthew Sakumoto, who is a virtualist and clinical informatics physician champion based out of San Francisco. Dr. Sakumoto, thank you so much for joining us today. We're very excited to hear what you have to say.
Thanks so much. Happy to be here. I'm happy to be Matt number 2 here.
Yeah, so we'll just go 1 and 2. So Dr. Sakumoto, I just gave just a very brief introduction of who you are. I know you have just a tremendous amount of experience. So for the audience, if you wouldn't mind, please just give yourself a little introduction.
Yeah, for sure. I think you encapsulated most of what I do. So I'm a virtual primary care physician in San Francisco, but it's a hybrid model. So I also care for patients in the office as well. So I get to actually meet my patients. And then the other part of my life is really around the informatics piece. So like, how do you help both clinicians and patients use digital health most effectively and efficiently? So those are kind of the main areas that I focus on and continue to work on throughout my day-to-day.
So I know for us, one of the really exciting things, why we were excited to talk to you is that you do so much virtual care. And you are a virtual first primary care physician and a physician champion, towards virtual care. Would you mind sharing, when did you first start caring for patients via telehealth?
I've always been super interested in care beyond the clinic walls. I think even during medical school, but I think telehealth in terms of specifically video visits, I started doing that during my clinical informatics training at UCSF. So again, always like the idea of care beyond clinic walls and reaching out to patients. And then I really realized you can meet them in their homes. You can kind of meet them where they're at, meeting patients where they're at, through video visits. So I did a lot of that. I did telehealth before it was cool, but 2019, not much before the pandemic, but set up a pilot project through UCSF, basically doing video visit urgent care, just to improve access, because to physically get a spot in our clinic took a while, but if we could meet patients at home and offload the patients that were coming in, that it was safe to do so, I started doing some of that. So that was 2019, and we were doing maybe about 5 visits a week. So then the pandemic hit, and that pilot project of mine actually became UCSF's COVID video visit screening clinic. So it went from 5 visits to I think doing it was a high number. It was like 80 to 120 visits a day, running 12 hours a day. I think we ramped up to close to 40 physicians at one point to really help with that COVID video visit screening. So got to see telehealth at scale and be part of that scaling. And then since then just was all in on virtual care. And since then have worked at a bunch of different startups, and currently I'm at another community practice doing, again, primarily virtual care and telehealth.
So thank you for sharing that. And you brought up the pandemic and that you were doing telehealth, pre-pandemic, and then obviously you've been doing it since then. What was it like as a physician? And I know you were one of many, but you were really kind of at the forefront within your organization of doing this. What was that like for you during the pandemic?
I think for me, so particularly, again, I'm an internal medicine primary care physician, so mostly outpatient based. It was a way to really help. I think for me, that was actually my first thought. It's how could, I have a lot of colleagues that work in ICU, emergency rooms, and in the hospitals, and they were just getting destroyed by the amount of patients that were coming through. The clinics were empty, right? So how can we help? So I think that was my first thought. And it's one of those things where you kind of just start doing it, you hop on. It's different. It a lot of it felt like medical school, where I'm relearning how to do the physical exam, relearning how to do diagnosis via video. So there was a learning curve to it, but also kind of this level of just again, really just wanting to pitch in and help while my colleagues are actually physically there on the front lines.
What was different about the physical exam part, or how did you adapt that part?
Yeah, there's a lot of, I call it the virtual physical exam, right? You can't physically listen, you can't do a stethoscope for most of the time. You can't listen to the lungs. But there's a lot of things, and you rarely have vitals as well, right? Like you don't have a pulse oximeter to check oxygen levels, but there's a lot more functional testing. So I would ask the patient, can you stand up and take a lap around your apartment or take a lap around the room and come back? Do you feel short of breath? Yes. Okay, I'm concerned. Let's send you in. Or do you feel short of breath? No. I think you're okay. We can watch you for a day or, and then we'll check in tomorrow. So I think rather than just taking a number and kind of treating patients called the e-patient, so, based on just like the numbers in the chart and things like that, you start to rely on just art of observation and really, really trusting patient report. So I think like trusting the patient to say like, how are you feeling? Let me know, incorporating the patient in that decision making a lot more than I did when they were physically with me in the exam room.
Would you get much self-reported vitals? Did people have blood pressure cuff or, anything like that, or maybe on their smartwatch or?
Yeah, no, fair question. And all of the above. So I think the number of people with home blood pressure cuffs is pretty increasing. They're pretty cheap. You can get them at a pharmacy. And for decision making, particularly around like COVID things, that was less important. Like, and same thing. You can there's a number, right? Is your blood pressure 120/80? Or when you're standing up, do you feel dizzy? Like to me, that's a symptom that like correlates with a relatively low blood pressure. So again, it's same thing. It's functional testing for patients, and they can kind of self-report their symptoms. And you're like, so rather than, so I guess that's the difference. I would say instead of treating to numbers, so instead of treating to a specific oxygen level or treating to a specific blood pressure number, it's like, do you feel dizzy? Do you feel short of breath? And in my head, I'm starting to recalibrate these with, okay, that usually is correlates to a lower oxygen saturation or correlates to a lower blood pressure. And then briefly, some of the other things, particularly like kind of height of the pandemic, so like mid 2020s, late 2020s, you would get creative. I remember specifically there was one kid, I was like, you might have COVID. He says he feels hot. So he didn't have a home thermometer, but he had a home meat thermometer. And I was like, okay, you're afebrile based on that. So we're good to go. That's it. There was a fair amount of creativity, I think, that happened as well. The first year of the pandemic.
So you just brought up that just triggered a question. That's interesting because you have to kind of be like a Swiss Army knife of like what tools are available, to try to diagnose these people. And since you operate a hybrid model of both virtual and in person, how do you feel your ability to diagnose people virtually during the pandemic when you just weren't seeing anybody in person, and then once they were able to come back and you could care for them in person? How do you feel your accuracy was, I guess, in terms of diagnosing folks?
Yeah, great question. I think one, it's a learned skill, the ability to do virtual and diagnosis at a distance. I felt that learning curve. So I said I was not as good at doing it in March 2020 as I was even in December 2020. So I think you learn how to do it. The two axioms that I tend to use are both around time. So like one, time makes up for touch. So the physical exam where you're able to listen to the heart and like put hands on it and do that, you can't do that through a screen. But the nice thing, and that's the other half of this axiom, is like the greatest diagnostic test is time. If I see you today and you say you feel kind of run down, not so great, maybe a little short of breath, I was like, okay, we can check in tomorrow, and we can check in 2 days from now and 3 days from now. And you kind of have time as a test. It's like, okay, are you overall getting better or worse or about the same? You don't really have that luxury as much when you're in a urgent care or a regular clinic. You kind of see the patient, and by the end of your 15-minute patient visit, you have to make a decision. Treat with antibiotics, don't treat with antibiotics, send to the urgent care, don't send to the urgent care. So the luxury of being able to say, I'm not sure, let's watch it, and actually come back in 1 day or 2 days or 3 days helps me make the diagnosis better because I have more data points. I have 24 hours, 48 hours, 72 hours of time to say, like, are you getting better, worse, the same? And is this more likely to be a viral illness or a bacterial illness?
So it's just fascinating how the pandemic has moved, just digital health and digital tools forward. How about, you mentioned that you're doing maybe like 5-ish virtual visits pre-pandemic, and then it went up to 80 to 100, sometimes per day. Mm-hmm. How has your practice changed in kind of the mix of virtual and in person? Right now?
Yeah. So my current practice is 80-20. 4 days a week, I'm practicing care virtually with my team. It's not just me. So it's myself, a nurse practitioner, and a nurse, all caring for a patient panel. So it's a mixture of video visits and a lot of just messaging. So a lot of messaging with patients online to help them walk through their different symptoms. And then 1 day a week, I'm in clinic. So again, where I get to see, we reserve those for things that truly need to be seen. Vaccines, pap smears, things that have to be done in person that can't be done through a screen.
So I guess one last follow-up question, at least for me on this. So now that you're operating kind of 80-20, 4 virtual and 1 person, within your organization, are you the only one that's operating in that kind of schedule, or are there others?
Yeah, no, great question. So we're a franchise model of sorts. So I'm the 4th pod of these different kind of team-based virtual first primary care groups. So there's 4 of us, each of us with our own primary care panel, us with our own team, scattered geographically throughout the Bay Area. And the reason it kind of works geographically is because we have that in-person part where it's kind of hub and spoke of sorts. So that's the hub. So we tend to have patients that are in that geographic driving-ish catchment area for the few times they do have to come in.
We have these conversations with folks all over the country every day. And so it seems like many providers who offer virtual care, they're starting to get more appointments on their calendar than some of the in-person folks because it's just so convenient. Would you say that that's holding true for you guys, or are you noticing any kind of difference in terms of your schedule because of this, the way you're offering service?
Yeah, 100%. I mean, I think there's just, you get rid of a friction point, right? Which is driving and parking. So I think even to fill a slot on a virtual schedule, you can do within minutes. If you have a quick cancellation, there's a patient that can easily fill that spot versus in a traditional brick and mortar practice. If someone cancels with 20 minutes notice, the chance of you getting someone else to come take time off of work, drive, park, and come in to fill that slot is low. So I'd say the no-show rate is lower, and then just the slot utilization is also better because the barrier to starting an appointment is, do you have a phone? Do you have internet? And can we get in touch with you?
My takeaway from that is that, patients who are seeking care, there's a higher probability of them actually getting that care virtually than if it was in person, just due to parking, due to all these other types of circumstances and events that could happen that may prevent them.
Yeah. Yeah. And I'll actually take that one step further. It's I kind of use this meeting could have been an email analogy. So think of the meetings that you sit in and you're like, this is a waste of time. This could have been an email. There's a lot of even video visits that patients have that for a blood pressure check-in or for a medication refill. Those can just be messages. So like I said, I mentioned a lot of my time is spent, my team's time is spent triaging messaging. So that's kind of the other part too that we tend to tell patients is like, hey, just message us first if you need something, and we can probably take care of it without even having to do a video visit.
Yeah, that's a great point. It makes total sense. I know we try to operate within our organization too, of how do we kind of minimize meetings and use other modes to make things more efficient. So switching gears just a little bit, because you are unique in that you are, very forward thinking. You're trying new, ways of caring for patients, kind of being a leader within your organization of other physicians in the way that you care for folks. But you're also involved with some startups and different things. So I know you're a mentor at Matter, and you have a background in startups. So I would love to know, we know you're obviously passionate about, medicine and healthcare and caring for patients, but what else are you passionate about? And how does that kind of all play together?
Yeah, I think I love marrying the two. And it's that idea of being, I call it a boundary spanner. I've used this description for myself and kind of like-minded physicians like myself, where you're able to take knowledge of one, just like medicine, like how does medicine work? How do you treat patients? But also medical systems. So like I've trained in large hospital systems, both in academic setting, community setting, understanding that piece, and then marrying that with like all the really cool things that are possible out in the startup community. So like who's like really pushing the envelope of ambient listening devices, a lot of the machine learning AI hype, some of it's hype, most of it's hype, some of it's actually like legitimately cool, and you're able to put into ready for prime time and ready for practice. So I think for me, I like being able to, again, take my understanding of medicine and healthcare systems and then say like, what are the broken things? Where are the needs? And what are these different startups that are doing things to fix that, and kind of marrying the two and being that go-between.
So I know we spent quite a bit of time talking about kind of current state, what you were doing before the pandemic, kind of how things are operating today. What do you think the future holds for telehealth? What might the next, 2, 3, 4, 5 years look like? What do you think is on the horizon?
Yeah, I think right now a lot of people are looking at telehealth, again, particularly video visits, as a way to substitute stuff that we do in an urgent care or in a clinic office. And I want to flip that in two ways. One, I actually push it both higher acuity and lower acuity. So I think there's a lot of things that we can just do out of the office, things that being able to promote wellness, promote preventative care, and like less reactive. I have a runny nose, I want to have a video visit. So I think we can increase that, move up the timeline, and again, go from reactive to proactive care. So I think being able to do a lot of preventative counseling, wellness promotion, again, through telehealth, meeting patients where they're at. You can kind of catch them at work or at home and not have them, again, take time off of work, park, and come to like a clinic that's more focused on sick care. And again, meet them where they're at and provide care in the home and promote wellness actually in the home. So that's one half of it, is kind of moving upstream, moving more preventative. And the other area that I think is really, really exciting is kind of being able to do higher level of acuity things in the home. So that's the hospital at home, tele-ICU kind of idea, where take patients, out of the hospital safely, obviously, but you're able to do that monitoring. And like when you're in a home environment with family, not eating hospital food, like the ability to just heal faster and heal better and have a better experience, I think is so much better. So again, I see it moving on the two opposite ends of the spectrum, kind of out of the clinic and then more back into the home, and taking some hospital stuff and moving it into the home as well.
I also think, just going back to some of the messaging you were talking about and sort of triage you're doing there, I think that is going, I think there's just a lot of opportunities. Just like you said, this meeting could have been an email. Mm-hmm. I think there's a lot of opportunities there. Is your organization operating in a value-based care model that allows you to do that? Or is it just some sort of extra service that you're offering patients?
Yeah, no, excellent question. So it's interesting. The answer is yes and no. So I'd say overall, the organization that I currently work with is like largely legacy fee for service. So like, there are hospitals in the system. The goal is to generate revenue per visit, per encounter. I'm slightly, actually completely protected from that, in as much as our current panel, we actually only take patients that have HMO insurance. So by design, we're value-based. Our goal is to actually prevent hospitalizations and ER visits, and we have a lot of data and processes to help us do that with our patients. So I'd say my specific clinic that we work in functions in a value-based mindset, and I think like that's really, I want to say close, like the only way that telehealth will thrive is to put it in that mindset. Because again, the goal is to not have billable video visits. The goal is to have just decrease total cost of care and improve like total patient wellness.
I mean, it's probably going to take a really long time for these organizations to transition from, a fee for service to value-based care. But it does seem like there's a whole world of possibilities that open up, because I rarely hear of physicians that are, doing any kind of messaging. Usually it's maybe the staff is looking to do some messaging because they've got to, exchange some information or forms or book an appointment or whatever. You do, obviously, I think, therapists that have a clientele that on a regular repeat basis, they're usually, texting and whatnot, but you rarely hear about care being delivered in that format. And I think that is going to be a big part of the future, but who knows how long that will take to move to value-based care. But I think that is something extremely exciting that you're able to offer people.
Yeah, and one caveat that I'll put on that is actually, I would not be able to do message-based care by myself. It's by design. We're team-based, value-based, virtual-first primary practice, and that team-based part is so important. So that I split my inbox with our nurse and our nurse practitioner. So it's that ability for us to. It's a team, and I think that's what makes it fun too. Is the things that I truly get the practice at the top of my license, because a lot of the things that are like, can I refill this medicine? Sure, the nurse tees it up and it goes through. And then it's like, I have this complex question about 2 medication interactions and possibly a medication side effect and a symptom. All right, we're going to forward that up to Dr. Sakumoto, and he can sort that one out. So it's definitely a team-based thing, because the patient doesn't know what level of care they need. So and that's on the medical team and the care team to help sort that out.
Yeah, well, very, very cool stuff. So, a lot of our audience is going to be, decision makers, health leaders, managers, so on and so forth. You're out on the front lines. You've been on the front lines. You were an early adopter, a pioneer before the pandemic, and I would say still very much a pioneer with, 4 days of virtual, 1 day of in-person, and the messaging and this value-based care that you're doing. What types of things would you want to share with the leaders to help shape and guide, the future of healthcare?
Appreciate that. And I think the message I have is video visits and virtual care can actually just be, I would say it's less sexy than it sounds. So in the way that you have a stock portfolio and you have your stocks and bonds, virtual care, particularly value-based virtual care, can just be your bond market, right? It doesn't have to be, you can still make money on fee for service, but invest in the infrastructure to have like a strong base. The reason that this resonated with me so much was the person that hired me on in my current role, she had been doing it for maybe about 3 years prior. And I was like, hey, this peak of the pandemic, how's that virtual practice going? And she goes, I told her every other system I've seen is just getting killed during COVID because all of their surgical volumes are down. Financially, it's really tough. And she goes, nothing's changed. 2018, 2019 to 2020, everything has been exactly the same because we're providing virtual care and we're getting paid per patient per month. So I think a lot of time, again, when times are good, you focus on the fee for service, but invest in your bond market, so to speak. And I think that virtual care, value-based virtual care, can be that provider.
Yeah, that was a great analogy. Thank you for sharing that with the group. You were quoted in a recent AMA article titled "To Excel with Virtual Care, Listen Closely and with Empathy." You had said that telehealth really brought back the home visit. What is missing from a virtual visit that you wish you had?
I really want to shout out my co-presenter with that, Sarah Krug. She's a fierce patient advocate. And I think for me, I see a lot of patients, but I didn't get to hear a lot of patients, if that makes sense. So I think getting to hear kind of her thoughts, how she perceives telehealth just from the patient side was super, super helpful. So we co-wrote a paper and we co-presented this idea of digital empathy, particularly on this AMA webinar. So I think pieces that we have missing from the virtual visit, one, more time with the patient. I think it's always nice. So I think that's the biggest thing. And that's just something that we wish for in medicine in general. It's just to kind of, there's so much medical stuff / administrative stuff to get through that there isn't time to build on that personal relationship. So I think like that's the piece that I think, particularly in primary care, makes such a big difference, is being able to build that doctor-patient relationship.
So that's an interesting point. Do you notice, again, since you're hybrid,
Yep.
Do you notice any difference in the kind of relationship building or the efficiency of a visit, virtual versus in person?
Virtual is far and away more efficient. I think there's levels of, and I don't know if that's just because people like in their work lives started doing more, Zoom calls and video visit calls, but like I will routinely get through my video visits faster than a equivalent complexity patient in person. I think it's a patient mindset. They come into it being like, this is transactional is like a little strong. Like I'm here with a couple of tasks that I want to get done, versus the clinics. A lot of times it's both a medical encounter, but also sort of a social check-in, if that makes sense. So I think if we're reflecting back on it, that's been the difference I've seen. So I think just working harder to make efficiency is good, but I think working harder to make the video visit both a social visit and a complete the medical tasks. Balancing that is going to be important moving forward.
We hear that often about just how efficient virtual visits are, how they can just care for more patients in a given time period than in person. I wonder if it has anything to do with it could take 30 to 60 minutes to drive to your provider's office for a 5-minute visit and then have to drive back, wondering like, I spent all this time in my car. I want to spend a little bit more time with my provider just to feel like it was really worth it.
Yeah.
Versus clicking on your calendar from one appointment to the next, and you can kind of get right back to what you were doing.
I think I 100% think that's part of it too. It's like wanting to get your money's worth, so to speak, out of it.
Yeah.
I think the other piece that helps me I'm thinking back to, I worked at a couple of other startups prior to my current role. What really helped me kind of talk with patients, it's that idea that like in an office, both the patient and I knew that I needed to make my decision, again, by the end of that 15-minute encounter. There's that safety blanket of, again, for both myself and the patient, saying like, hey, I'm not sure if you need antibiotics for this cough, but you can check in tomorrow. And again, that barrier to checking in tomorrow is so much lower that they're like, okay, yeah, that's fine. We'll check in tomorrow. Versus like if they were in the clinic with me, like I'm thinking back to my in-person urgent care days, you might haggle over like starting an antibiotic, yes or no, for an extra, 5 or 10 minutes, because it's like you have to make that decision by the time the encounter ended.
So yeah, it makes a lot of sense. With all the time that you're spending caring for patients, I'm curious to know how you have so much time to spend being as active as you are on social media and really putting out valuable content for folks. So I would love for you to just share with the audience, because we have had the opportunity to take a glimpse at some of the stuff that you're putting out there. Could you just talk a little bit more about your passion for doing that and also how they can find you?
Yeah, no, for sure. So social media handles, easy to find, Matt Sakumoto, MattSakumoto for both Twitter and LinkedIn. Those are the main parts that I tend to, my main haunts, I guess. And I think for me, I always did like social media, I think, prior to the pandemic, but like just being so bored during the pandemic just kind of got me more onto Twitter, wanting to connect with people just because we were stuck in our houses. So I think that's what kind of got me into it. But the other part is like, particularly Twitter is a very vibrant community, both from a medical standpoint and from a digital health innovation standpoint, that I think so many people are doing cool things, sharing what they're doing. And for me, like that was a really good way to just keep my finger on the pulse of what's going on out there. So I think for me, like I love learning from other people. And I think the other reason why I'm so active on it is in the same way I like to share kind of things I find cool and interesting, again, particularly in the digital health realm.
Well, I'm sure people really appreciate the time and effort you put into it. So thank you very much for that. So I think now comes competition time.
Yeah, we've got a little a bit of fun in store here. We've got an optical illusion today. So this is from the New York Post. And I'm going to bring up an image and you're going to count the number of tigers or the number of cats. I'll give you a little hint. The number's probably a lot higher than you think. So we'll go ahead and bring it up and the audience can play along too. And I'll give you guys, maybe a minute or so. And you tell me how many you think you saw. Now some of them are, kind of baked into the background. So see a lot of intensity through the cameras.
I know it's mostly. I always say the art of observation was brought back by the virtual physical exam, so I feel a little bit on the spot here.
Yeah, well, I have spotted a couple that are incredibly hard to see, so I have to believe there's more that I'm missing.
Well,
I see 8.
All right, we got our first answer.
All right, I had 11.
Oh gosh.
I may have double
Good
counted.
thing you're caring for patients than I am.
11 is a strong answer. I think the answer is actually 12, but 11 is impressive. I'll see if I can point them out. There's 1, 2 in the rocks. Then you've got sort of the family of 4, so that's 6. 7 in this bush over here.
Mm-hmm.
8 next to the parrot, really hard to see. I think this one is suspect, but you can kind of see the eye of a tiger here. So that's 9, kind of blurred into this the top of the trees in the top center there. Then you got 10. There's kind of one ghost one another ghost one, and then 2 more here. So wait, is that 13? Let's see, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So they just keep appearing.
Yeah, I'll take my whooping on that one. Just have
It's tough to the
try to be
screen
better
share.
next time.
It was through the screen share. We'll cut you some slack.
I appreciate you throwing me a bone because I consistently lose at these things. So, well, Dr. Sakumoto, thank you so much for joining us today. I know Matt and I have learned a lot from you, as I'm sure our audience will as well. So for anybody who's viewing this, please feel free to hit us up with any questions or comments. In the next episode, we're going to have another great digital health thought leader for you. Please make sure to like and subscribe to this. And thank you all for watching very much. Dr. Sakumoto, have a great rest of your day. Thank you again on behalf of all of us here at MEND and everyone watching.
Thank you.
All right. Take care.
Thanks, everybody.
Thank you for watching today's episode from the Getting Down with Digital Health podcast. To learn more about MEND or to access more content, please visit mend.com.